welcome to this Transformative Simulation in Practice webinar. We've got a really good speaker and I'll be handing over to Sharon in a moment. These webinars are proving to be valuable in real time and as a resource that you can go to later. I'm just going to finish off with a comment from Nicola, who can't share camera or microphone. That's okay at the moment. You can type questions into the chat or comments as you go along if you wish. Okay, over to you, Sharon.
Thanks, Andy. Yeah, so as Andy said, we've got a great speaker this week. We've got Dr. Rashid Mohammed, who's from Norfolk and Norwich University Hospital NHS Trust in England. And Rashid's been doing some fantastic work in this area for quite some time now, and we've been really privileged to hear bits about it. But this is the first time I think we're really getting a bigger picture of how that work's evolved and what's currently happening. And so I'm really excited to see this one. I'm excited to see all of them, but this one's going to be fantastic. And I'll be quiet now and hand over to Rashid to share his slides with us and talk us through this work a bit more. Thank you.
Thank you very much, Andy and Sharon. It would actually be useful to begin discussing a little bit about what transformative simulation is. Like every time, simulation as a tool to transform health and care through collective understanding, insight, and learning. And it would even be quite useful if I describe to you what are the pillars, the 5 pillars of transformative simulation and the 7 different intentions and the 4 Ds that actually make simulation transformative. Because only when we realize what these things are, then the real work of implementing any change that we come up with, that starts. Like we got a few examples in the previous webinars by brilliant speakers, but to go through the details, rather than that, I think I should signpost you to the ASPE Transformative Simulation SIG web page, which describes it in much better words than I can. And actually, it will form the background of what I'm going to present, which is the focus of my talk. Basically, that what is the real world opportunities and obstacles that transformative simulation can bring for us. So when I'm alluding to so many terms and terminologies and different sciences and the complexities of the real world, the question is, can our multidisciplinary teams, do we expect them to know the whole breadth and depth of all these complicated terms and sciences? And if they do not know that, can we still make it easy for them to engage with transformative simulation? And that is the focus that I'm going to take in this webinar. So let me welcome you all from Norfolk and Norwich. I'm an emergency medicine consultant here. But I'm going to take you through my own journey over the last 6 years, which started as a simulation education fellow for Health Education England. And then my experiences with different trusts within the region. And finally, my current work as a multidisciplinary faculty at the Norfolk and Norwich. And how, despite many of the team members not knowing the very intricacies that I alluded to when I started the webinar, how we can actually engage a wide variety of people in different kind of aspects and different variety of simulations and problems. So let's begin with emergency departments, which are really fast, which are non-stop. And really, you need something which does not disrupt what's happening. And what we find is in situ simulation as a mode of delivery just before COVID clicked for us, because our teams did not need preparation, and we could basically work with the premise that 2 of the co-facilitators, so it depends on co-facilitation, and it depends on at least 2 to 3 members who are participating in these in situ simulation sessions, which don't run for a very long time. The actual visibility is only for 20 minutes, but the background preparation, including what we call meta debriefing, and the preparation might take an hour, but it does not really impact on the day-to-day running But what it does is, rather than an episodic simulation, it creates multiple series of simulations, and it focuses on a learning culture for our team. And in the course of the last half decade, we have basically accumulated a huge wealth of resources with different topics ranging from homelessness to early pregnancy. And what it has done for us is that we can always find a sort of less busy area within the big A&E, and we can go into minors, and maybe uh, we can kind of play a simulation which explains to us what we can do with that amputated finger in a patient's pocket, or what can we do with the parent who is accompanying, unfortunately, a neonate who has just arrested. But very quickly, after COVID started finishing, we realized that this is the same methodology and the approach that we can probably not just use for latent error identification and intervention, but we can use it as reactionary simulations to deal with complaints. And even for very nuanced topics like staff well-being. And this is really what gave rise to a larger scale project in Papworth over a period of 6 months to 1 year, where we formed 5 different teams from intensive care medicine, respiratory team, stroke team, where each of the team had 3 different facilitators at 3 different levels who identified themselves to be at the discovery, growth, or maturity stage of facilitation. What that meant is basically they were taking ownership of clinical problems that happened the year before, which were serious incidents that they had themselves faced. And with that ownership, they created kind of iterative simulations for a very specific problem area within that complaint or that serious incident. And they were running these different simulations, which could be how to improve the response to massive bleed within the theater, or what to do when on the operating table we realize that a post-TAVI, which is a procedure, that a patient develops stroke, and how to minimize that. Why do we miss respiratory failure, or what should be our response if something happens which causes an elderly patient to fall within the hospital? And it was not, again, coming back to the difference between an episodic sim and doing simulation to change culture by making it a series, by making iterative and giving the ownership to the people who actually face it. And in fact, the recurrent question that came to us was, how do you know that simulation is causing the change in your systems? Or is it actually something else that is making the change? So people are looking for that quantitative data which will tell you that simulation is somehow linked with the improvement or rather change. But we realized that there is something else that transformative simulation does for the teams. And it is not just the apparent improvement, but there are some other areas which are the 7 I's. And few of them could be the inclusion and influence. So let's and also they are related to the pillars, which is what is actually the purpose. Is the purpose only to look at a graph or a data that changes within our system, or is it something else? So I think this is a good time for me to pause now that I have, rather than giving you answers, brought up some questions. So in the chat, I have actually put a link um, to something that we very often use between the facilitators. There's the 6 thinking hats. What it does is when one of my creative colleagues brings up a new innovative idea for a simulation, at that time I start thinking it could have some major kind of dangerous impact or a threat to our team or a risk. So we are in a different kind of lens when we are looking at an idea that is presented by one of our colleagues. So rather than that, the 6 thinking hats, what it does for us is at one particular time, we are using the same lens to reflect on our experiences. So you could use the chat, or you could use the link that I have posted on the chat if it is still visible, I don't know, to just share your one-line experience of using transformative sim, which basically means that using simulation for a non-educative purpose. So let's just take 2 minutes of pause, and I'll come back to it.
We don't see the link.
Okay, let me post that again in the chat.
Oh, idea board. Yeah, got it. Thank you.
This will sort of help me if I'm going in the right direction with the presentation, to see like what your experiences are. And in my further presentation, I'll be sharing the experiences that we have developed over the last 5 to 6 years. Okay, so no experience is actually good in a way, because that is the focus of my talk, as I said, that many people are going to be specialized in their own area of expertise. And this is where transformative simulation can help, where uh, people who are facilitators can realize this and basically make it apparent that you really don't need to have, you can actually contribute with the expertise that you have, and we can contribute with the expertise that we have. So someone has said reimagining possible futures. So that is a very innovative way of looking at it. Use of Pew's chart for accurate recording. Also consider benefits gained through experience. So these are two different things. One is like taking the cognitive load of a particular process by using a tool, and at the same time sharing other people's experience and looking for benefits. So unearthing hidden system issues and dynamics that are contextual. Okay. So keep coming up with these ideas whilst we proceed, and obviously Sharon can just interrupt me and bring up any thoughts if you have at any point. So whilst we are thinking on these 6 aspects of our own experience, so what are the opportunities transformative simulation can bring, and what are the obstacles that it can help us deal with? So very similar to what ideas that we have brought up, what we realized is that people have their own expertise, and they may not have expertise in the field of transformative simulation at the outset. And this is what led, whilst we were doing the 6 month to 12-month project, we got the opportunity to look at people's perspectives of what they think of using transformative simulation in an organizational level for non-educative purposes. The reason that they were sharing these experiences with us in a phenomenological study, where basically we know of what reflections are. Reflections are based on our actions, and actions are usually linked to beliefs. And when we start addressing our beliefs, that is when reflexivity comes into the picture. So we were able to use reflexive thematic analysis to understand what the perspectives are of the people who are involved in a transformative simulation project. And what we found is that they had just gone through in the last year with these serious incidents, and they found the experience to be very personal. They found that the whole story was in front of them, and they could see what had gone wrong, looking at it retrospectively. Few of them who realized that it was challenging, they realized that the buy-in has to be from people who have influence in the organization. And the people who were doubtful, they realized that it was so hard to measure. So we come back to the term dirty data. So dirty data is something which may sound quite unacademic, but it sort of gives us the meaning to understand that not everything is the data itself, but there are other elements within transformative simulation which helps us to influence people, and it helps us to include people which we would have not otherwise been able to include just by posting a learning experience like a poster or an email for our team to understand like what is the new change. And that is what led us in the last ASPE conference to kind of try this different method of looking at simulation, which is instead of looking at simulation in our A&E kind of emergency systems where we think it's a major disaster preparedness or a major cardiac arrest or a traumatic arrest or trauma management that we need to do simulation for, we started looking at bread and butter things that our team members they face day in and day out, and we call it high occurrence low acuity events, and how we can use simulation for change of culture rather than one single episode of simulation, but every day, maybe every week, to change the culture. And that is where transformative simulation was the key for us. And the key lies in basically something, a tool that doesn't depend on one single facilitator or an education team of 3 people or just a patient safety team of 5 people, but rather each and every team member of the wider multidisciplinary team, they take ownership of that particular bread and butter problem that they face day in and day out. They create their own opportunities. And the job of the transformative simulation team within the organization is to empower them to be able to deal with it themselves. So how do we do it? So rather than going into the complexities and the academic discussions, we bring them back to why they want to use simulation as a tool or the broader sciences to deal with the problem. What are the opportunities that we can help them create? So we are trying to use a very simplified why, what, and finally, how do you do it kind of framework. And the question is posed to our team quite often that can you really make something that matters to the team, or are you really going to cause a change? So I tell to them that today we are 4 to 5 people over a period of 3 months working on 3 to 4 projects. How about in a period in over a period of 52 weeks, that is 1 year, if we have 10 people taking ownership of their own clinical problems, and we are at a stage where we can use the flash based in situ simulation, which takes about 20 minutes of actual work in the clinical space. If we only deliver 2 episodes per week, how many staff are we going to be in contact with this transformative simulation project if we do it for 52 weeks? It turns out to be 400 staff. Even if there are 200 who are doing it as a series, who are repeatedly being involved, we will have 200 new staff who are being involved in such a daily kind of culture based transformative simulation exercise that happens in our departments. So that is what the vision we are trying to share with other people within the department, which can empower them. And what can empower them is transformative simulation and the whole background that I signposted initially, which is on the transformative simulation webpage, where what it highlights is we start with the person who is taking the ownership of the clinical problem. And we say that you can't do it on your own, you need a team. And once they come up with the team, they start realizing who really matters in this. What is the purpose? Is it the staff? It is a well-being issue. Is it a discrimination issue? Or is it a patient-based issue or a carer-based issue? Once we identify that, is there anything that can be qualitatively or quantitatively be monitored in this clinical problem? And then we start looking at what does it mean for the people who are involved? What are the obstacles and what are the opportunities? This is the kind of approach which many people are able to now relate in our department. So now, after having gone through the previous past experiences over the 5 years, I'm going to come up with kind of share with you a half a dozen to a dozen of examples that we are currently undertaking. And these are really recent over the last 3 months. And I also want to start with one of the clinical or one of the problems that we are currently using transformative simulation, the approach that I just said, to showcase that it is not just clinical problems. One of my sim technician colleagues is working on how the access, availability, and support of sim technicians can be improved in a large trust where multiple simulation exercises are happening in different areas of the trust, at the same time, and there are limited number of sim technical staff. Very often, we just think that they are related to room facilities and equipment without realizing that how crucial their input is for the backbone of faculty support, and their timely troubleshooting is necessary. So if they run tabletop simulations and they realize that a simple fact that how many times they get phone calls every day for particular problems, and can they use that as a measure to improve the feedback and satisfaction score that comes over a period of six months to 1 year. That is what we are looking at as one example. On the other spectrum, end of the spectrum, we look at clinical problems like undifferentiated patients coming to the front door in the emergency department or in the rapid assessment area where undifferentiated unwell patients come. So one of my colleagues is looking at how to use virtual reality in the context of transformative simulation and the other tools to improve decision making. So we are looking at the cognitive aspect of decision making for undifferentiated patients, be it unwell ambulance patients or children who are less than 12 months who are coming in an undifferentiated way, and how we make those decisions. So this new project, which is flash based, but also using the intentions, the 7 intentions of transformative simulation, is what we are working on currently. So looking at this progress over the last 5 to 6 years, it might look like we are somehow going linearly towards what in the past I used to use the Kirkpatrick evaluation framework quite often to look at it in a very linear aspect, that gradually we need to kind of improve the behavior of the team and then look at return of investment and results. But the real world, is it really that linear? And that is the kind of challenge that transformative simulation has thrown to me. And what it has left me with is it is not really linear. So let me expand on this using one example that I have been working over the last 1 year and I continue to work. So this is something that Sharon has helped me understand using the sequential simulation that she has worked quite a bit, I know. Is our team in the last 1 year faced the problem of violence against staff, especially from mental health patients who are undifferentiated patients in our team, in our department. And we look at the clinical process. And sequential simulation helps us to kind of focus on one particular aspect, which is how do staff approach these patients? Is it really safe, the way they approach? Does that de-escalate from how we approach them? And it is easy to actually build multiple flash-based simulations for that particular aspect and reinforce our staff safe behavior and how they approach, and to look at the priorities of how far you need to stand and who to call if something like this happens where there is a threat to staff safety. So that is quite easy. But what is not easy is zoom back and look at the whole process again. And once we have understood, we can go back and see what prevented triaging of these patients appropriately. So if they really abscond, have we documented their physical appearance? And that leads to a different kind of modality of simulation. And if they do become aggressive, do we now need simulations which will include the porters or the security staff? Are we actually ignoring them within the process? So these are the kind of questions that this simulation posed us. And when we zoom out even further, there are even more questions, because the purpose is not so linear. In fact, the question that is posed to me is, how about a nuanced possibility of stigma being of these vulnerable patients, and how do our staff look at these patients from that stigma point of view? Or, like I mentioned, are carers and patients really part of the learning experiences that we develop and the kind of responses that we develop in our processes and pathways? And these underrepresented people, for example, the police who are involved within the A&E with multiple sections and legal sections that they bring patients with, do they have a say in how we actually respond to these patients? So this example basically highlights the real world complexities, which is where transformative simulation can help with understanding the opportunities as well as the obstacles, and really empowering the people who belong within the system. And it is not actually linear, as you can see. So what we did so far is that we use sequential simulation to understand the clinical process and to intervene in it. We conducted kind of tabletop simulations involving the mental health volunteers who very frequently are in the quiet rooms where these mental health patients are. And we used transactional analysis, which is a term they use in psychology, and we conducted these analysis of why people behave the way they behave in these circumstances. And to further expand on this, the 2-minute summary video was shared with people who matter, for example, mental health liaison teams, the nursing lead, so that we can influence the people who can buy in the approach that we are using. And finally, we conduct simulated forum theaters where 10 people are involved in each forum theater. And it's just a 2-minute simulation, but we pause it at different intervals of, say, for example, 20 seconds and 50 seconds. And we ask them, what would you have done in that particular point? And what we saw in both these forum theaters was this 2-minute video actually led to almost a 2-hour discussion. And the experience was so rich and deep that it brought things that we never would have achieved by just a poster or an email or a kind of a one-to-one discussion. So this is where the concepts of the 7 I's, which is the transformative simulation, like intervention, involvement, inclusion, and influence, comes for a very simple linear pathway, which may look linear but is not really linear. And where does it apply? For example, if there is a mechanism where we can monitor how in out of hours are elderly people managed in the A&E, and during that monitoring we realize that actually our measure is dropping down the baseline. The intervention number 5 and 6 was based on this transformative simulation exercise, where we could actually look at what improves what we are monitoring already. It might again sound like I'm looking for a data, but then what about something more nuanced, like discrimination against international medical graduates and the unconscious bias? What we realized that doing similar transactional analysis model of tabletop simulation and conversation with them, we got feedback like, I have no idea what I need to improve so that people perceive me better. Sometimes I feel like I'm being over explained to, because it is not English that is the problem, there is something else. So this gives us an opportunity to understand these problems, not just based on quantitative metrics, but something else, which is where again I signpost you to the 7 I's, like involvement, inclusion, and intervention. So what is the practical step we are trying to do? We realize, first of all, that the multidisciplinary staff have their own specialization and expertise. We cannot expect them to have the whole understanding of what we are trying to mention when we say transformative simulation. But at the same time, we can have common grounds. We can utilize their expertise and share our expertise from the simulation point of view. And what we do is we take them through a 3-month cohort. And every 3 months in this flash intentional transformation, we do some synchronous teamwork based on the problem that they have taken ownership of. And then these different these different problems that they are working on, based on the context, we also provide some personalized mentoring of where they might need specific help on a particular specialty. So we might invite someone from the quality improvement team, we might invite someone from the patient safety team, and then that kind of increases the kind of change ideas that we develop. And then we also develop asynchronous references that they can go back in that period of 3 months. And then at the end of 3 months, what really happens is they identify their own problems. We help them with the ideas. We give them tools like model for improvement, if it is an improvement based transformative simulation, or the other modalities of transformative simulation expanding on it. We help them design and develop and also deliver the flash based simulation sessions if they are appropriate. And by the end of 3 months, what we realize is just trusting the process, they are able to present what they have done. And then it iteratively goes on if that is what they decide they want to work on an extended manner. So all this has come up from the last half decade of multiple feedback that we have got and we have documented and we have learned from. So what are the highlights for me here? So what we realize as might be a simple linear process in reality is actually quite complex. But our role as transformative simulation facilitators is to help people with the confusion. Although it is not complex, that doesn't mean that it should be confused. We are looking at the bread and butter problems that people can take ownership on. And that is why we are coming up with so many examples to showcase that transformative simulation can be used for variety of possibilities. But you are not alone. You need a team to collaborate with. And that is how we can share our vision and extend the opportunities and deal with the obstacles using the team's expertise, different expertise. And finally, the most crucial aspect is to trust the process. In the beginning, it is going to look simple. And then at some point, you will feel like it is quite confusing and complex. But if you are within the team utilizing each other's expertise, then the process will take you to the end point. And the end point is really not an end, but it is a process that continues. So it is not an episode, it is a series of changes that leads us to a learning healthcare model. So for me, what is important from transformative simulation is to give the ownership to the people who matter and empower them with the knowledge, but over a period of time, so that we can create the opportunities whilst we deal with the obstacles as a team. And that kind of real world change is what transformative simulation can help us with. So that was my brief presentation. And I think it would hopefully generate some ideas, thoughts, and questions that we can take further.
Thank you, Rashid. That was really fantastic. I'm sure everyone's got so much to say, but for me, I love that end bit then, trust in the process, because I think that's so true. Often we want to control everything. We want to already determine what the outcome is because it feels safe and we'll be secure in that what we've achieved, we know we've achieved. But I think you're right. I think really trusting in your colleagues and each other and that things will emerge is huge. And it's a big mind shift for us in healthcare because I don't think we're used to letting go in that way. So that was amazing. And then the other bits as well, which were, I think, really stood out to me was exactly what you were saying about the complexity. We keep saying about trying to simplify it, but we're missing, you're absolutely right, we're missing the opportunity because we're so often everything's simplified and then we get some new policy or change forced upon us because someone has said, from a simplistic model, this will work. And we're missing that opportunity of actually we can figure things out together and at the same time share the mental model and drive the change forward together. It might be complex, but it's actually more efficient if you think of it that way, isn't it? In the long run.
Yeah, can I just come in for a moment? So thank you. There was so much in there. It's like having a really good gourmet meal and then being asked to sort of think about it straight away afterwards. But in the ideas boards, I just want to mention a couple of things. One is the quote, changing the system, not surviving it, which for me epitomizes the simulation for education and training as a tool to deliver the best outcomes as you can in an imperfect system, which is imperfectly replicated in simulation. And another comment, which was under the cautions hat. This is the De Bono hat, isn't it? Under the cautions hat, what could go wrong? And that just was an interesting way to look at a couple of the things that you mentioned in that dense and thorough presentation about selecting what it was that you were going to do, and this difference between what I describe sometimes as idle curiosity and a deliberate attempt at discovery. So it's quite a useful way of thinking about what you're going to do actually. Does this stand a chance of leading to a discovery, an enlightenment about something that could be improved, or is it a more idle curiosity about what would happen if? And that is less directed. And so again, it's about trusting the system. It's trusting those pillars to direct you to something that is likely to be a discovery, rather than aimlessly indulging in curiosity. And then we go into all that stuff about the data and the Ds. And Nicola from Quality Improvement, I'm guessing, Nicola, is talking about a little bit about dirty data and quick data, and this seeking for what is discovered and democratizing it so that discoveries aren't hidden by failing to give people voices. This is where all the inclusion and involvement comes in, I think, and empowerment. So that's my rather muddled thinking at the moment. But I think that what we've done in the past, and still do to a certain extent, is we can throw a lot of resources at trying to find out what went wrong when something massive goes wrong. But the problem with that is that when something massive goes wrong, it's usually a one-off. It's a unique set of circumstances. So there are no generic messages to come out of that. And what you've been doing here is throwing a little bit of resources at business as usual, and having the courage to accept that it's complex and that the discoveries might be a bit dirty or quick when they first come out, but looking at business as usual, because that's where the transformations need to be based. I think I'm making sense.
Absolutely. I think I'll just extend that by saying that, I mean, Nicola obviously is an expert in quality improvement. And I have had the opportunity to have a discussion about this. And I'm sure that dirty data is an academic way of expressing it, rather than saying quick data or just enough data, which is more appropriate. However, like what Andy, you mentioned is, many a times we look at simulation as a very kind of regimented way, and that is where we use it for like life support courses or things like we want to teach people what they need to do rather than learn from it. And I think that's where transformative simulation really helps us, that we don't, that we kind of get accustomed, or we accept the uncertainty and say that this is a method that will help me learn what's happening. And I think that is where the real opportunity is from transformative simulation.
Yeah. I'm going to have that carved above my desk, mate.
I've just allowed everyone's mic and camera, so if people want to come in and talk, they should hopefully be able to now. If anyone wants to come and respond to some of those insights and reflections.
Can I ask who posted changing the system, not surviving it? Would you care to expand on that a little bit?
Maybe I haven't enabled everyone. I thought I had, but maybe it's...
I'm enabled on mic, but not on camera.
Ah, okay. Sorry, maybe I've half done everyone then.
But that wasn't my comment, so I'm keeping quiet.
Well, please come in if there's anything else. I mean, is this something people are trying to do themselves, or does it feel like quite a new way of looking at it? Or is it challenging your thinking, or is it exciting? Any thoughts?
For me, it's lovely seeing simulation coming out of the closed box that it used to be in and into the real life practice. And I think the agility, it allows you to be much more agile in what you can choose to do and what you can explore purposefully, as Andy said, which I think is the really important word here, real purposeful exploration. And the doing sort of building it iteratively, putting on layers of it iteratively, rather than kind of coming up with a plan. I used to go and do observations of sim, and this is how we do the sim situation for this, and this is what we do. Whereas actually with this, you're doing much more learning. As Rashid said, it's a much more learning piece. And actually when we go about things in those ways, we often come up with solutions that are much better for us wherever we work. And that's much more rewarding for you guys who are doing this all the time than, as you said, I think you said at the beginning about those top-down things like, oh, this has gone wrong, now you need to do that. Doesn't work where I am. What do I do now?
And I think that's quite hard, isn't it, as well? Because you've got really experienced, knowledgeable people who've spent a lifetime trying to understand healthcare from whatever perspective you do. And then all of a sudden you get this top-down thing that apparently is simple and should just be done. And it's quite, it's quite frustrating, I think, isn't it, when you don't get ownership of that place you work and what you do. And your knowledge isn't really considered in that sense, even because we've got all the knowledge in the space, haven't we? We just need a place to bring it together. Figure it out.
Can I I think that's very aligned to one of the comments on the white hat facts is unearthing hidden system issues and dynamics that are contextual. And for me, something around simulation as the jester's hat, as the democratization of inclusive voices. This would be a really genuine, purposeful discovery, that unearthing hidden system issues that are contextual. I wouldn't like to write the paper on that, but I'd love to. I'd love to have a go at it, and I just wonder whether the person who posted that would like to extend on it.
I'll come in while we're waiting, because you're just making me think of and I say this as a researcher, and I think sometimes this is where we're going a bit wrong when we're using simulationist ways, again talking about trying to predetermine the outcomes and know exactly what data to collect. But I was recently at a conference where we were talking about this, and people were saying what's frustrating is the things that emerge are actually seem so small, but they're so impactful on the system and the change that happens. But because they don't seem big in a typical way that you would measure it and normally report back or research, it feels like we do need to recognize the opportunity of that impactfulness. And I'll give an example that I give all the time. But there was that I was involved with a simulation where they were implementing a new diagnostic tool for esophageal cancer as a breath test. And it was just, the assumption was made about where it would go in the pathway, which seemed obvious at the GP centre. No concerns there. And they brought esophageal cancer survivors just to say this would be the new care pathway. And they said, oh, this is really great. It's a very invasive procedure to have a biopsy. And so if we can just have a breath test without a biopsy, this would change so much. It's really beneficial. But you've got this all wrong. And they went, well, what do you mean we've got it wrong? We said, well, this is a disease that generally presents in men and it presents late. And the reason it presents late is because men don't like going to their GP. So if you put the breath test in the pharmacy where we're getting our Gaviscon for our symptoms, you'd probably pick up a lot more people. Now, impactfully wise, it was such a small comment. Yet you think about the savings in terms of lives and patient outcomes and costs in the pathway. It was, if someone would have measured that and known that we could measure it, it's probably huge because it changed the whole pathway. But again, you couldn't had the foresight for that. And so there's something about how do we capture those really impactful things that emerge that we don't really know they're going to emerge until we're in the moment. Nicola.
Well, I think that's really where co-production comes in. And I think the thing we have to remember is that for every big thing is made up of this series of little things. So actually, we should not be surprised that it's the little things that have to be done in order to get to the big things. It's just the people at the top often have no appreciation or understanding of those little things. That is the place where clinicians in particular, practice. That is where you make those changes. So I think that's really important to appreciate that. And there's a really good video, if you go, I think it's on the NHS Scotland hub from Trish Greenall, that talks about the boring little things, which is, really, I think, really important. And the second thing to say is, until I know we're all, we're qualified as healthcare professionals, aren't we? We're so bright, but actually, I really am astounded at how often we don't ask patients, and how I've got this really great quote, which is goes along the lines of patients not difficult to engage, but easy to ignore. And I say that to my trainees, my learners, all of the time, actually just ask them. We overcomplicate stuff because of of everything that we know. Just ask them what matters to them, and you will just get a simpler answer.
Yeah, that's so true. I love that saying. What was it again? I want to write it down.
Oh, I'll put it in the chat, because somebody's just come into the room I'm in.
Yeah, although it is like a simple, like I think you said boring little things, but it's almost it's parallel with the comment on the creativity aspect, changing the system, not surviving it. It's very revolutionary, and I think that can also be a hurdle for people who are thinking that this small change of not doing it with the GP, but rather doing the breath test at the pharmacy is actually a huge change in the system, the way the funding works, the people who are like, are they going to feel comfortable doing the breath test in the pharmacy at the first place? And I think simulation really, when you're bringing like these co-produced aspects, bringing everybody together, like the involvement and inclusion aspect of it, and then discussing through as to what is actually in the mind, the complexity of why the funding can't change, why the system can't change. It is revolutionary in that aspect, but it has that kind of depth and the power that really requires the change.
Yeah, do you know, I think you've hit the nail on the head there, because it's even if people know it, you're right, people usually revert back to what's not possible in the systems and the complexity. But there's something about the simulation, and I've seen this as well, where it kind of it recognizes that, but it allows everyone to kind of problem solve together. And I remember we did this like collaborative healthcare remodeling, and because you had a patient at the center of the simulation, it reminded you that there was a real person involved in all of this. It just got, people kept trying to find solutions, and even when those solutions weren't easy and weren't working, everyone just kept going back to the drawing board to collectively figure it out. So there was something quite empowering about, yes, it's not easy, the systems hold us back, but if we're all figuring it out together bit by bit, we can use our knowledge to kind of untangle the mess we're in a way. Oh, that's it. Yeah, patients not difficult to engage, just easy to ignore. That's brilliant. And boring little things. Yeah, great quote. Have we got anyone else? Anything else that's coming to your minds? Do people feel like they can do this kind of simulation where they work?
That's where we need to share more and more examples. And I really found the in practice webinars, the previous two, which I think the recordings are still available on the Transformative Sim page. And they are wonderful examples of so many different things. And it just tells us that it can be done. And I'm sure more people will be encouraged to use this.
Yeah, and I'm always astounded by the creativity and how people are using it. Every time things come up that I think, gosh, I don't think I would have thought of that, using it in that way. And I think your point about the hats was really insightful for me, because you're right, just that slight shift in lens of how you're seeing it and its opportunity or potential, or really impacts what occurs as well, doesn't it? If you don't see what lens you're kind of putting on from a hat perspective. Hi, Nicola. We're in the room. We can't, you're on silent.
I think, is my background back to front?
No, it's all right.
Oh,
No,
it's all right,
I can see it. Yeah.
On Teams, it does that thing,
Yeah, I think it's on your side, it's back to front,
Yeah,
but the
yeah.
other people can see it. But it's
If
confusing.
the boring little things piece is wrong, then I'll look at it and share with Rashid the timings when she mentions it. But it's a really good watch.
Yeah, no, that's brilliant. Thank you. Amazing. Well, if we've got, is there anyone else wants to share? If not, we can move on to the final ending.
I think I would move on, Sharon. I think we've
Yeah, if anyone remembers anything, please feel free to post on the idea boards, and that will be a quick reference for me as a reflection and feedback. Thank you very much. I can't thank enough to the organizers for inviting me and giving me the opportunity as well. Thank you so much.
Oh no, Rashid, it's been such a pleasure, and I've really enjoyed that. And again, it's completely opened up my thinking and how we look at this. So very exciting. So thank you everyone for coming. Again, as Rashid said, this is available on the ASPI website. So please do go and have a look, or signpost people this way, because I think this is really helping us as a community evolve together in this work. Next one we have in exactly a month's time, we have Colette Laws Chapman doing a TfS in practice webinar, and she's from Guy's and St Thomas's NHS Foundation Trust. She was the immediate past president of ASPI as well, and she's going to be looking at giving examples of how she's been doing transformative simulation with her team for many years, but also starting to show how she's been more and more intentionally using the framework and having that purpose-led design lens. So I think that will be really interesting as well to see how that's developed and grown. So please do join us. We'll send out the registration link soon so you can sign up. And Rashid already mentioned it, but if you want further resources, it's infographics. We've got games and videos, and we're always adding to the different papers that are being published and different things. We're about to have a new website actually as part of ASPI, hopefully in the next few weeks, where we'll have a really nice transformative simulation resource page. And please do let us know if there's anything else that would be really useful. We're always working together to kind of develop stuff, and because transformative simulation, we all use it in different ways or look at it in different ways. We're always open to kind of thinking about how we can do it differently, or what might help people in practice or education, or however you're using it. So let us know. And of course, just to remind you all that we do have the ASPI conference registration is now open, and the abstracts submission, I think the deadline is the 28th of April. So please do put your abstracts in. And also super early bird registration is open at the moment as well. So fantastic. Anything else, Andy?
No, there's a comment from Lucy Tyler about using it in a healthcare university setting. And I think that's a really interesting avenue to it that will be explored in the future. I think that we'll be finding out how these sort of co-creation ideas work. I don't know why this is stuck into my head, but the overall content of this webinar has reminded me of the book Moby Dick, and the book's called Moby Dick, but it's not about the whale. It's about the human beings around the whale. And in a wider context, it's about the environment in which whaling is such a advantageous business to be in, and this sort of layering of the power dynamic of what goes on and the contextualizing of what's happening. It's great to be able to step back from the great whale and think about it in terms of how all of this stuff actually happens. And it all takes place in Starbucks.
Well, that's a great note to end on, Andy. Excellent. Right, well, let's say goodbye, everyone. Thank you so much. It's been a pleasure as always, and we'll hopefully see you at the next one.
Thank you
Take
very
care,
much,
everyone.
everybody. Have a good day. Bye.